Uh, Good evening, everyone. So on behalf of Sri Lanka College of Specialist Family Physicians, we are discussing case presentations on most of the Thursdays with the trainees in family medicine, particularly registrars. So today, this case on chronic headache is going to present by Registrar Dr. Waruni Hettiarachchi. She currently attached to PH Panadura under the guidance of me as a trainer, Dr. Malkanthi Galhena, and as well as the college president as well. So our the focus for this type of the case-based discussions is to give the knowledge about the common, the encounters in general practice. That is the common presentations of our patients of different age and sex categories, and as well as from the perspective of trainees, so they must know how to know the correct method of history taking, as in by using the holistic approach, that is not only the physical but also social and psychological, and as well as to go ahead with the focus system examination in order to confirm your tentative possible diagnosis with etiologic factors that you have detected for this problem, and to find out the possible clinical diagnosis at the end of the examination. And then you can go ahead with the correct counseling about the patient and the correct, the management in general practice in first contact care to provide best evidence-based, safe patient care for our patients. And the trainees will learn, right, during this training to go ahead accordingly to provide the safe, very much evidence-based the first contact care. That is the main objective of this, the presentation, as well as not only to learn by herself or himself as a trainee, to share your knowledge among other colleagues, right, in other colleague trainees, to give the correct, the insight about the patient management with the discussion of guideline management as well. So today, Dr. Waruni Hettiarachchi is my trainee, going to discuss about this patient who came with headache. Waruni, it's over to you, and I'm there to support you. So please go ahead.
Good evening, everybody. Good evening, madam. This case is, we have found this case while doing the family medicine clinical appointment at Base Hospital, Panadura, under the supervision of Dr. Malkanthi Galhena, consultant family physician. So today we are going to discuss this case. He's a 47-year-old male who is a farmer who cultivates vegetables in large scale. He complains about a headache for 2 weeks, and he had background history of chronic headache for 2 years. In presenting complaint evaluation, we found that he had that left-sided frontal headache. It is kind of a throbbing or pressing type of headache, lasting throughout day and mainly increasing at morning hours, associated with facial pain. Particularly over the left supraorbital and maxillary area, which increases when he looks down, and it is not radiating to anywhere else. And pain scale according to him is 5 to 6. And this pain is precipitated with dust exposure, direct sunlight, and while working in outside. He had pain medication time to time, antibiotics, but he didn't get any permanent cure for his headache. That's why he encountered in our family medical clinic. Once pain started, it lasted with daily symptoms throughout last 2 weeks' time. It makes him to unable work outside, and he didn't have any fever, but having generalized malaise and fatigue. He had a history of frequent sneezing at morning, nasal discharge, which is thick, purulent in some occasions, frequent throat clearing, and post-nasal dripping also noted. Recently, he noticed loss of sense of smell. His wife is complaining about his loud snoring and halitosis in his mouth. He had background history of chronic headache, which also having daily symptoms once it occurs, and nature and the type of headache is same as current presentation. This headache is not associated with any aura, nausea, vomiting, not being worse with loud sounds, but worse with working in a field with dusty environment and direct sunlight. He didn't notice any worsening of his headache with any alcohol. Also, he is not taking long-term medication other than time to time paracetamol and the steam inhalation. He did not complain any tearing, red eye, or nasal congestion-like symptoms with this headache. No severe eye pain, visual scotomas associated with this headache. He did not have any neck pain, history of any head trauma, or postural misalignment due to occupational activities. He didn't have any fever, even in pyrexia, drenched in night sweats, but he complains generalized fatigability. But there is no unintentional weight loss or loss of appetite. He didn't complain any tenderness over his scalp, no any other joint involvement in his body, and the headache is not getting worse with cough, sneezing, and also he is not getting up, waking up due to headache, and no worsening with head position. He didn't notice any convulsions, gait abnormality, or any double vision or motor weakness throughout the course. His sleep is not disturbed, no difference in his appetite, and good interest on his hobbies and activities. And according to the past medical history, he is not screened for the non-communicable diseases, and family history is not suggestive of chronic headaches and like migraine, and past surgical history is nil, and no surgeries involving sinuses. Drug history is not continuous medication for more than 3 months, and allergic history also nil. He's thinking about this chronic headache because he's thinking about any sinister cause underlying his headaches will cause in this the persistent. And social history, he lives with his husband and 3 children. He had a stable income, and he's taking alcohol occasionally, and he's a smoker, but he has reduced number of cigarettes per day. He knows the importance of quitting smoking, but he is still taking 5 or 6 cigarettes per day. On examination, what we found
patient is husband. Patient is husband living with wife and children, no? Right, okay.
Yes. On examination, general examination and CNS, he is thinly built man, mood is normal, apparently dressed, not pale and afebrile. Gait, there's no gait abnormalities, no cranial nerve defects except hyponasal voice. Sensory motor are normal. No eye signs, no nystagmus or double vision. Sinus examination, tenderness on skin over the left maxillary, frontal and ethmoidal areas, no evidence of periorbital cellulitis, no neck stiffness. Nasal examination, nasal septum is not deviated, no nasal anatomical abnormality detected, and inflamed nasal mucosa with enlarged turbinates, which covered with thin film of discharge, no nasal polyps. Throat is normal and not inflamed. What are the differential diagnoses in this case we have to think of? Shall I
Others
move
can-
on?
Okay.
Waruni chronic sinusitis.
Yes, good. Any other diagnosis? We have to exclude here.
Nasopharyngeal
malignancy. Yeah.
Okay, nasopharyngeal carcinoma, okay.
As he is a farmer, there is a possibility of aspergillosis involving sinuses.
Yeah,
That's
fungal
good.
infections, okay.
Yeah. What about the possibility of cluster headache?
Yeah.
As he is male patient and young one, there's a possibility of getting cluster headaches also. Is it, madam?
And maybe
Yes.
chronic,
My differential.
yeah, maybe space occupying lesion as well, no? Slowly growing space occupying
Yes, ma'am.
lesion for, 2 years, right? Okay. You
Okay,
start.
my differentials are chronic rhinosinusitis with acute exacerbation, possibly of bacterial infection, and migraine headache, tension headache, or cluster headaches. And we have to exclude that space occupying lesion. Actually, final diagnosis, we have taken that chronic sinusitis with acute exacerbation, possibly bacterial, and precipitating factor is chronic dust exposure in moist environment. And investigations were done in the OPD, and full blood count that is normal, and ESR is 23, fasting blood sugar 97, and we have done a sinus X-ray on him as a primary investigation. And this is his sinus X-ray. What we can see is here in frontal sinuses, but there are bilateral haziness also there. And also we can see that the mucosal thickening in left side in frontal sinus, but we couldn't find any other abnormalities in maxillary or ethmoidal sinus because this is 3D, 2D appearance of the sinuses. So we can't tell exactly the other features here. So, but finally we diagnosed that as chronic rhinosinusitis with acute exacerbation. And the management, what we did at the family medical clinic, we explained about chronic sinusitis and precipitating factors, and particularly to the patient because he is a farmer and working outside in the agricultural environment. It is moist and dusty. And so we discuss
Waruni?
about the precipitating factors.
Varuni,
Yes, madam.
so, just to disturb you, it's a good point raised by the audience that it may be, due to fungal, the sinusitis, that is aspergillosis, because farming and the environment is more prone. But how can we, exclude that? Was by history, the patient, has on and off, the exacerbation, acute exacerbation, and as well as, it's a sort of a chronic inflammation of bacterial inflammation, like, postnasal drip is yellow, postnasal drip with the exacerbation, and as well as the patient is having generalized malaise and sort of a chronic, the bacterial infection, right? So that's how, because in case of aspergillosis, patient might not have that much of, the acute, the complaints. So we have, the clinically, the differentiated that, right? But that is a very good thought. In case of safety netting, even still we can ask the patient to go ahead, and at the follow-up, we can think of if the patient is not resolving, right? Okay, now you can go ahead, Aruni, from your point. Varuni.
Yes, madam. What we did for the pharmacological management is, yes, madam. Hello.
You carry on. You carry on.
Hello. All right, madam. what we did for pharmacological management in this patient, we prescribe him on beclomethasone nasal drops for 4-week duration. We asked him to continue even though patient's symptoms has subsided. He should be continuing for 4 weeks time. And
that is not
we
the
have
drops,
prescribed
that is the spray, not the
spray.
drops.
Okay.
Yeah.
And azithromycin 500 milligram daily for 2 weeks and loratadine 10 milligram daily for 2 weeks because he's having allergic rhinitis part also. So for the pain management, we have given him that Panadine 1 gram SOS.
Sorry to disturb you, dear. We have given 1 month duration, azithromycin only for 2 weeks, but the loratadine and the nasal spray to at least to go ahead for 3 months, but this time we issued for 1 month to see the follow-up response. Okay, I corrected.
Yes, madam. Yes, madam.
And with the preventive advices for the dust.
And yes, madam. We advise him to prevent dust exposure by using a face mask, and when he spraying chemicals at fields and adequate water intake, and we advise about those things also as non-pharmacological management. And also we plan for review assessment in 2 weeks time with the other investigations, and we wanted to see him again till he gets over this chronic infection, get over the infection, and we are plan to manage further management in next time. And I want to go through a little bit more about chronic rhinosinusitis regarding this is according to the American Academy of Otolaryngology. And we all know about.
Sorry to disturb you again, because
yes,
in the management we have reassured the patient saying that it's not the serious illness that he was thinking, right? And as well as we have inspired him that the cause for this particular illness is the dust environment. So where it can be from the farming environment as well as from the bed linen and these things. So we clearly advised him to avoid that. And with that knowledge, the non-pharmacological and pharmacological management has been established. And we told him to come, the follow-up, the importance of follow-up for at least monthly follow-up for 3 to 6 months time in order to give him the proper relief. Right. So with that management, he agreed to come with those reports which we have ordered, and in case if not responding, we told him we must go for the further investigations like the CT brain and MRI brain like that. But anyway, the patient agreed to comply with our management plan. So because of that, but it's a very common thing among general practice. So because of that, we have got so many cases have been missed by some other physicians, right? So because thinking and giving them lot of investigation sets, that is because you are not listening to the history and not examining the patient most of the time. If you don't touch the correct with the correct technique, if you don't exert pressure on the sinuses, 4 sinuses, you are not going to hear this patient, the maxillary. But other patients, common thing is ethmoid sinus. If you didn't touch, sinusitis. If you didn't touch over the sinuses of ethmoid sinus, so you are going to miss the diagnosis, and you are going to so many other investigations. So because of that, it's very, very important for you all to go for the correct technique of examination as well. And not only that, to give him the correct insight about his disease, right? That the patient must know the disease, suspected disease, and the follow-up plan. Otherwise, patient will not be compliant enough to come for the follow-up. And this is kindly please mute your phones, please. And then because of that, it's very important for you all to do, the lot of things that other than the pharmacological, and you have to go ahead, even antibiotics 2 weeks at a stretch. Sometimes pharmacy will call me and ask, why madam this much of antibiotics? Then we have to tell them the importance of it. So no you issue, because of this only we wrote it like that. So otherwise patient will suffer again and again, no complete the cure. So because of that, maybe the different causes. Sometimes some patient may be having nasal septum deviation, or sometimes the patient may be the not allergy. It's not the dusty exposure. The clean environment patient is there, but the taking the night, doing night duties, and sometimes taking regular alcohols, which affect the ciliary functions of the nasal and sinus mucosa, where I ended up with inflammation. So because of that, from the history, you have to find out why this particular patient got this sinusitis, the etiology, and you need to address that at the management. So that is why we are taking holistic history taking, right, to find out the etiology as well. They come to the diagnosis and find out why this patient got this. So that has to be addressed. Now having that art, and you need to have the knowledge to apply the best evidence based in the management for the patient. So that is why she is going to give you some more knowledge about the guideline management. It's okay, Aruni, over to you.
Okay, madam. And I'm going to discuss a little bit about guideline management. This is according to the American Academy of Otorhinolaryngology, ENT surgeons. And they discuss about this problem, and they provide guidelines on management acute and chronic rhinosinusitis. And this is occurs chronic sinus. I'm discussing about chronic sinusitis here. And chronic sinusitis occurs in all ages, sexes, and ethnic groups. And this is common throughout the general population. But the thing is that it is not acute. There is no acute prevalence. It is difficult to measure, as because the symptoms are low grade, but it is chronic. Both people and healthcare professionals also ignoring the symptoms most of the time. So the acute prevalence is much greater than that. But what they said is it is general population prevalence is more than 10%. And it is significantly decreased the quality of life. What they say is quality of life is worse than other chronic diseases like heart failure, asthma, and COPD. And it is primarily inflammatory disease, and inflammatory disease that is occasional exacerbations, possibly with infections. And chronic sinusitis, rhinosinusitis is associated with sinus edema, impaired mucociliary clearance, and edema-related obstruction leading to retained mucus and bacterial infection. And chronic rhinosinusitis can be accompanied by some other non-specific symptoms like headache, fever, cough, halitosis, fatigue, and dental pain. Those are some kind of rare symptoms, but those are very specific to chronic sinusitis, like halitosis. Our patient also having that. And the duration, actually definition, they have provided that chronic sinusitis is lasting more than 12 weeks with or without acute exacerbations. It is called as chronic rhinosinusitis. And when the patient is having 4 or more annual episodes of rhinosinusitis that can, without any persistent symptoms in between, that is called as recurrent acute rhinosinusitis. Chronic sinusitis also, they are classified into 2 groups, with or without polyposis. And they have given that differential diagnosis of chronic sinusitis, that is include allergic rhinitis, non-allergic rhinitis, vasomotor rhinitis, and nasal septal deformities and other deformities involving nasal cavity, and non-rhinogenic causes of facial pain. Example, neurogenic disorders such as vascular headaches, migraine, cluster headache, trigeminal neuralgia, and other facial pain syndromes. And this is sinuses. Actually, we all know about these sinuses. We have to examine all those areas in our examinations. And when considering sinus anatomy, those are blind-ended pouches that line by the ciliary epithelium, which is drained through a small opening that is called ostium to the nasal mucosa. And ciliary clearance of the mucus that is generated inside the sinuses is done through the ostium, which is osteomeatal complex. It's naturally done by the ciliary action of the ciliary action. And pathophysiology, that osteomeatal complex obstruction is thought to be the central issue in the most of the cases. And persistent inflammation, bacterial biofilms, mucosal response to fungal infections, or Staphylococcus superantigens also playing a role here. Underlying factors like allergy, viral infections, air pollutants like dust environment include the local inflammatory causes lead to sinus mucosal swelling, and that lead to osteomeatal complex obstruction. And this will lead to sinus flow obstruction that lead to mucosal clearance is impaired and sinus pooling of mucus inside the sinus cavities. Then superadded infections are coming, and biofilms also forming with the chronic infection and inflammation. Anatomical abnormalities like blocking the osteomeatal complex, septal deviation, concha bullosa, abnormal bony cells, foreign bodies, craniofacial abnormalities, and scarring, trauma play another role. And when we consider about the infective causes, it divides into three phases: viral and bacterial and fungal. Viral causes mostly rhinovirus, adenovirus, coronavirus, and influenza virus. Most of the time, it is a viral causes. If it is bacterial, there are some other bacterial infections. Fungal infections also there, but it is very rare. And allergic causes are also playing a big role here. And seasonal allergens, perennial allergens also playing a good role here for the chronicity of the disease. And the bacteria they have identified most commonly is the Staphylococcus aureus, this is 50%, gram-negative rods 20%, Haemophilus influenzae 4%, and group A Streptococcus 4%. And this is somewhat different from the acute rhinosinusitis, that is very common oral mucosal commensals, but here it is pathological Staphylococcus aureus, most common one. And higher incidence of having anaerobics and polymicrobial infections in chronic sinusitis. And etiology other than infective causes, genetic and physiological factors, cystic fibrosis, primary ciliary dyskinesia, and some structural factors, severe mid-septal deviation, and environmental factors like allergens, environmental pollutants like dust, smoking, those are also playing a big role in chronicity of the disease. And what the criteria says is diagnostic criteria in chronic rhinosinusitis, according to the guidelines, it is they said that four features that should be there for more than 12 weeks. Of two of the four criteria, it should be persistent more than 12 weeks. One is mucopurulent discharge. It could be anterior, posterior, or both. Usually it present in 50 to 83% of patients, and nasal obstruction is 81 to 95% of patients. Decreased sense of smell in 60 to 69% of the patients. Facial pain, pressure or fullness like symptoms 70 to 85%. Two of the features should be there for more than 12 weeks. Plus, there should be documented inflammatory signs like polyposis in the nasal cavity, or purulent or mucus discharge and edema in the middle meatus, and radiographic imaging showing inflammation of the nasal paranasal sinus. So we had to have the both criteria to be said that it is chronic rhinosinusitis. In our patient also we had that criteria, and radiographic evidence also we had in the sinus X-ray. This is another classification, International Classification of Headache Disorders. IHS classification also, they provide the same kind of criteria. I'm not going to go through these in detail. And what are the risk factors we are encountering in chronic rhinosinusitis? Strongly associated with ciliary dysfunction. It is cystic fibrosis, primary ciliary dyskinesia. Those are rare causes, but it is strongly associated with chronicity of the chronic rhinosinusitis. And aspirin sensitivity. There's a trade-off SAMTA. It is nasal polyposis, aspirin sensitivity, and the asthma. All together, these three features are coming together, and it is called trade-off SAMTA. And it is also lead to chronic sinusitis. Sinus allergic rhinitis also leading to predisposing factor. We discuss about that. And airway hypersensitivity and asthma. 36% of patient is having that chronic allergic airway hypersensitivity. And previous sinus surgery, that also leading to there can be some adhesions and poor drainage of mucus to the osteometal complex. Then this can lead to chronicity of the disease. And immunodeficiency, we have to consider if the patient is refractory to treatments. So we have to consider about underlying immunodeficiencies. It can be congenital or acquired like HIV. And severe mid-septal deviations, anatomical blockage, that also lead to chronicity. Smoking, we have to ask to quitting smoking is important. Environmental pollution, yes, in our case, it is dust exposure. History of asthma, poorly controlled lower respiratory tract diseases also leading to chronicity of the disease. And during our clinical evaluation, we have to consider about the duration, presence of risk factors we discussed previous slides, and facial pain and the pressure, nasal obstruction, nasal discharge, we have to consider, and we have to ask about headache. That is common thing they present with that. Sphenoidal sinuses, they present with vertex headaches and pain. Fatigue is very common among these people, and cough also there can be because of secondary to postnasal drip. Hyposmia and anosmia, that is uncommon, but they are not presenting with this symptom, but it is there. And fever also not common. Halitosis also not common. Dental pain we have to ask, and ear pain and pressure symptoms we have to ask. And other things actually we have discussed about these things, allergic rhinitis and surgeries, we have to ask about those things. And immunocompromised patients, we have to ask about the IgA and IgG abnormalities. We have to ask whether the patient is having those diagnoses. And examination of the nasal cavity, that is important, but we can do at the primary care level. We can do endoscope or if it is available, or headlight using with the nasal speculum. Tudicum speculum we are using here, and we can have some anatomical evaluation with that. Middle terminate and middle meatus, up to the level of that we can examine with this. Nasal endoscopy, that is available in secondary care, and by using nasal endoscopy, we can have the more detailed anatomy in the nasal mucosa and sinuses and sinus opening. And with that, we can take that samples for culture and all other procedures. And this is how we are going to examine with the Tudicum speculum. And we can observe that inferior turbinate, middle turbinate, and nasal septum up to a certain level. Then we can diagnose mid-septal deviations here. And And here we are going to show you that this is a middle turbinate. This is more pink in color, and this is the polyposis. What we can see here is more grayish color than this. The pink color has been disappeared in this polyposis. And investigations, standard investigation, gold standard is sinus CT scan. It is non-contrast CT scan. We can have the more details in chronic diseases. Disease like sinusitis. And other than that, what we can do is, I'm sorry, in CT scan, what we can see is ossification of the involved sinuses and mucus thickening, air fluid levels, anatomical abnormalities like polyps, retention cysts, and sinus walls. Anatomical abnormalities we can see in the CT scan. An MRI scan, it is reserved for further investigation of the patient who is having intracranial extension of the disease, fungal infections, and neoplasm. If you are suspecting that, we need to go into MRI scan. And endoscopy, allergy testing, of course, it is recommended in guidelines, but here, of course, we are not going to do it because it takes time. And nasal sinus cultures, we can't take that nasal specimens because it is mostly contaminated with other commensals. But if you can take that endoscopical guided cultures, it can get a good sample for cultures. Otherwise, no need to get any cultures from the nasal swabs. And complications of chronic rhinosinusitis, it is orbital cellulitis. It can spread into orbit through the direct extension. Initially, patient is experiencing orbital swelling and pain, and it progresses into visual changes, diplopia, blindness, and other cranial neuropathies. And intracranial infections also, one of the complications in chronic rhinosinusitis. It is meningitis, epidural abscess, subdural abscess, and sometimes brain abscess there can be. So as a clinical features, we can see that mental status changes, possibly with cranial nerve neuropathies. Other orbital complications are preseptal cellulitis, subperiosteal abscesses, orbital cellulitis, orbital abscesses, and finally it can lead to cavernous sinus thrombosis. If you can remember the anatomy of the sphenoidal sinus, it is around the cavernous sinus. So it can lead to cavernous sinus thrombosis. And osteomyelitis, that direct spread into basal skull bones, can lead to osteomyelitis. In that case, we need to consider about TB-like infective causes. And other complication is mucocele, that is benign expansile lesion that is slowly growing, but it is displaced the surrounding bone and other structures. So it is presented mostly common in frontal sinuses, and sphenoidal sinuses can be involved into that mucoceles. And management of according to the guidelines, they recommend is nasal saline irrigation and topical intranasal corticosteroids. Oral antibiotics are considered depending on the examination finding. And no antibiotics approved for the chronic sinusitis per se. If there is evidence to suggest that bacterial infection, then we can start. Antibiotic we have to use for at least duration should be shorter than 4 weeks. Long-term antibiotics that is needed more than 4 weeks, it should be considered if the nasal saline irrigation and topical corticosteroids are not working for at least 3 months. And when we consider about intranasal steroids, mechanism of action of steroid, we all know about that. replenish for the knowledge, but here it is reducing the pro-inflammatory and increasing in anti-inflammatory gene transcription, reducing airway inflammatory cell infiltration, and suppressing the pro-inflammatory mediator. In classes of topical steroids, first generation intranasal steroids, beclomethasone, triamcinolone, and budesonide. Newer preparations are fluticasone, mometasone, now it is available as sprays, not as drops. Adverse reactions, very minimal and local applications, and there can be epistaxis, headache, and nasal itching. And there long-term use, because we are using up to four weeks of this steroid, so they can consider about the long-term use of steroid, but systemic absorption and ocular effects are very little, and the lens opacity and other increasing intraocular pressures, they research about on that, but they didn't have any significant association with that. And duration of nasal steroid should be at least 8 to 12 weeks. Adequate treatment is necessary to relieve the pain. Otherwise, patient is coming again with recurrent of symptoms. And how to use intranasal steroids? They have given the guidelines, and like that, you have to instruct the patient how to use this, and how to keep the nostril inside the nose and towards the nasal nasal septum should be avoided. It should be lateral to the lateral nasal wall, should be aimed in with the nostril. And normal saline irrigation in the chronic rhinosinusitis, it has a great evidence that Cochrane review also saying that this is important, and because it says that improving symptoms, mucus clearance, enhanced ciliary activities, and disruption and removal of antigen, biofilms, and inflammatory mediators, and direct protection of the mucosa also observed with that saline irrigation. Common side effect is fluid dripping after the irrigation that you have to discuss with the patient. Irrigation can be formed with the isotonic or hypertonic saline solutions, and there are many devices, over-the-counter devices. We can prescribe that, and we have to educate how to do it. There are so many YouTube demonstrations regarding the saline irrigation, so you can give the direction to see this. This is one of the short YouTube YouTube demonstration of nasal saline irrigation. You can watch this leisurely after the presentation. And other therapies, what we can give is, we have to think about chronic allergic rhinitis, asthma, cystic fibrosis, immunocompromised status, and ciliary dyskinesia. So in that case, proper management of underlying chronic diseases should be considered in management of chronic rhinosinusitis. And smoke cessation is very important, and we have to improve, we have to counsel about that also. And surgical treatment, actually, there are a lot of surgical interventions they are going to do in secondary care. And if the patient is not responding to our treatments and the management, we have to refer to further evaluation and investigation like CT, MRI, and for the endoscopic sinus surgeries. What they do is basically re-establishment of the sinus ventilation by draining out of secretions and increasing the size of the openings. That is osteometal complex, becoming wider. And antibiotic guidelines for the sinusitis in Sri Lanka, I have taken this from the SLMA guidelines from the microbiological agents. Acute sinusitis, what they say is mostly viral, as we all discussed. And if it is persisting more than 7 to 10 days, oral antibiotics we can start. First line antibiotic is erythromycin, doxycycline, coamoxiclav, cefuroxime, clarithromycin, azithromycin, or levofloxacin. In resistant cases where gram-negative rods and anaerobes are considered, ofloxacin, ciprofloxacin with or without metronidazole, we can try those antibiotics. And chronic sinusitis, what they say is they need to be investigated because X-rays are not adequate for if it is unresolving sinusitis. So we need to go for CT scan and the MRI scans. Those are the Sri Lankan evidences, but fungal infections also rare in our country. What they say is case by case, they have to decide on antifungals, but not all. If you decide that if there is evidence of fungal sinusitis, so we can start antifungals. Otherwise, no routine use of antifungals in chronic rhinosinusitis. And in follow-up patients, we have to follow up long-term because of their symptoms are recurring and the pathology is running behind. So we have to follow up these patients for long-term. So major goal is to reduce the chronic inflammation and number of exacerbations that need antibiotics. And we have to manage the underlying diseases like asthma, allergic rhinitis, and all. Sinus cultures are not needed in each and every case. And take-home messages what our madam is emphasized is proper evaluation of the history and the precipitative factors are very important. And adequate examination is needed to locate that what is the infected sinuses. All 4 areas we have to check. And proper diagnosis and management is very important. In chronic sinusitis, precipitating cause should be isolated and it should be eliminated if possible, or otherwise it should be minimized. And adequate treatment with antibiotics, and if the symptoms are suggestive of bacterial exacerbation is needed. And these are the my referrals. And thank you very much for listening. This is long presentation, and thank you very much, madam, for supporting me and guiding me regarding presentation, madam.
Okay. Thank you very much, Waruni. It's a really informative and your skill has been, really well displayed. So this is what we want from trainees to, get the training for the presentations, because one day you are going to become a consultant and then you have to start training your students, trainees. Not only that, to expand your knowledge for the exam wise, it's very, very important, and to the practice the patient-centered, correct, correct management of patient. So it's really a good presentation. Once again, I'm thanking you, Waruni, for doing a good job. And it's open for you all to ask some few questions if you want to clarify things. You don't have questions? So what is the time now?
Now it is 4.
Right. So your take-home message, as Waruni also mentioned, to add that. So whenever patient comes with chronic headache with exacerbation, always you have to think, even though it's very clear now, we'll say for an example, chronic sinusitis, but you have to think about all possible red flag diseases and, try to, explore those symptoms and, to exclude. Otherwise, the same, the patient might come with the same complaint, like that headache, for an example, with, underlying possible sinister causes. So your skill must be, they are to identify a red flag symptom and as well as to a red flag sign by examination. That is why you have to, go through the correct, the series of history taking, including psychosocial aspects and particular worries. So then only you can find out the cause for that. So then you can nicely well exclude the other possible red flags where we can treat the patient and manage the patient well. Or otherwise, if you have any suspicion, right, by taking a proper history and after examination, we have to, do the proper coordination by referring the patient to the correct, the consultant. So that also another learning point, because we are not going to mismanage patients, because we always respect for the patient's life. So always don't, manage the patient by putting the patient's life into danger, because almost all the symptoms are coming to the patients are coming with their initial symptoms to the first contact care. So there you have to be very much alert, expand your knowledge to identify for each and every symptom what are the possible underlying, the serious illnesses that patient can be presented with same symptom. So that is the most take home serious message that you have to take right home, and just whenever you see a patient for even simple symptom, you think what is the most possible, most dangerous disease that this symptom can come with. So like that, you have to get your training. Okay, then, right, if provided that you don't have any, queries to clarify, I think it's a time to conclude the meeting. So thank you so much for the presenter, and as well as, our medical team who are always united at Panadura Base Hospital, including acting consultant Dr. Fasana and senior registrar Dr. Samantananda. And there are two Dr. Prasad registrar as well as two medical officers are helping for patient management and to discuss these cases. Thank you so much. Okay, good night for you all. Thank you for participation as well.
Okay, madam. Thank you very much, madam.
Okay. Okay, bye. Okay.
Good night, madam.
Good night.
Thank you very much, madam.
Okay, dear.